dear professors, dear audience, thank you for having me again. Day 2 is as good or even better than day 1. Thank you very much for having me. In 1996, Dr. Souza from Brazil changed the world that we know by proving that you can enter into the pericardial space without there being fluid around the heart. You can enter this potential space. This is an example. I apologize, the transmission is not perfect. I tried to do this late last night and it didn't quite work. But anyway, what you're seeing here is dye staining the tissue as you're entering right under the xiphoid process. Let me kind of point this out. So this is the xiphoid bone, and then the needle is coming right through underneath. It's staining the tissue, stains the pericardium, and then very faintly you're seeing a layer of dye around the silhouette of the heart when there is no effusion. This was done for the purpose of lariat occlusion, and we used a 90 degrees lateral projection for entry. Our objective is access to the anterior surface of the heart. When Souza first described his cases, he was dealing with Chagas disease, and they end up with a lot of scar on the inferior wall. And so you'll see his trajectory is more perpendicular to the heart, and then he enters a little bit. So the point is that 20 years later, we know we can enter to the front of the heart, to the back of the heart. He opened a new world for us by proving that the epicardium is accessible. Why do we even need to go there? The idea is that this is the thickness of the ventricular muscle. If you're limiting yourself to the endocardium, as we have been for the longest time, the ablation lesion will only have a maximum depth of about 10 millimeters. What if your scar is here, in the mid-myocardium? What if it is here, closer to the epicardial surface? And that's the kind of scar that is creating the ventricular tachycardia. You may be able to access this maybe from the endocardium. You clearly will not be able to affect this to a large degree. This is an example from dilated cardiomyopathies. And what you're looking at is late gadolinium enhancement. In this case, this is deep in the septum. You see this bright area. In another case, it's spanning the whole thickness of the lateral wall of the left ventricle. And in these two cases, in C, there's patchy fibrosis in different areas. This one, right here, and this one. The point is, in a dilated cardiomyopathy, you can have fibrosis that is in different areas of the heart, not necessarily following the coronary distribution, and secondly, in different locations within the thickness of the myocardium. So, what are the substrates where you necessarily, or you should be thinking about need for epicardial access? Clearly, let's get this out of the way. Idiopathic VT, where there is no underlying structural heart disease, is very unlikely that you will need to go to the The highest on the list is ARVC. We saw a fantastic case yesterday that was presented by our colleagues from Saudi, and that's pretty much what we're looking for. Right after that, it's true, out of the dilated cardiomyopathies, there will be some that will need that. But I have to admit to you that as a general EP person who's not in a referral center for VTs alone, I have not needed to do a lot of epicardial access. In fact, when I think back, I think we were doing it more 10 years ago, and we're doing less, and I think it has to do with the efficacy of the ablation catheters that we have now with the irrigation and so on. So, and better strategies also for ablation. You heard very elegantly from Stefano how he goes about the scar and reducing channels and so on. This kind of aggressive approach from endocardial ablation has really limited the need for going to the epicardial aspect, particularly in ischemic cardiomyopathy. But it's true that ischemic cardiomyopathies are on the list. Then you have a host of other things. Maybe sarcoidosis is one of the things that you might run into. But I agree with what Stefano also showed, is that the main indication for going epicardial is having failed endocardial. Earlier when we started and we were excited about it, say, have endocardial and epicardial. In every case you go, you don't know what you're going to need. That is not the case. You can always bring a patient back. Do endocardial, finish what you need to do. You got a good result, be thankful. You didn't, bring him back. This time say, maybe there were some things about the VT that could make me think about using the epicardial. So let's go through some of the criteria that different groups have proposed. The group in Penn, in particular, have been very active in this. Clearly, cure arrest duration. Okay, let's first think, what are these numbers about? The idea is that if your VT breakout is on the endocardial surface, it will engage the His-Purkinje system somewhere. Anywhere in the His-Purkinje system, it will engage in it. It will activate the rest of the ventricle using the firewire system that is the His-Purkinje. Now, this is located closer to the endocardial surface. The epicardial surface is very remote from that. So now you have muscle-to-muscle conduction going for a long time before it sees the first opening into the network of the His-Purkinje virus. Once you have that in mind, now the numbers, you can always keep them in your back pocket. But the cure duration will be longer, right? And though nobody has agreed, it's very hard to say that something is epicardial if your QRS duration is 120 or 140 milliseconds. You need to see a delta wave, a pseudo delta wave, very much like an accessory pathway. It's the same idea. You're activating muscle to muscle, right? And then the intrinsic deflection time is the time to the peak of your R wave. And what is the width of the shortest SRS? And then the other one that you could look at is the maximum deflection index. So all these are duration criteria. Let's take a look at one example that was, it's been widely quoted as an example. It's again from the Penn group. So this is a patient whose intrinsic deflection time is 112. The QRS duration is greater than 200. He has a prominent pseudo-delta wave at 56. The cutoff is something like 49. And the shortest complex is 157, which is longer than 120. And you can look at the numbers at any place, it doesn't have to be. But duration is not enough. You also need to look at morphology. If the activation is coming straight from the epicardium, then in lead 1, you would expect to see a QS configuration. Whereas in inferior leads, you will always have a positive deflection. Contrarily, if you're activating from endocardium, you can expect to have first the wavefront going towards lead 1, and so you'd have absence of a Q wave in lead 1, and more of a Q wave in the inferior leads. Understand, we're talking about dilated cardiomyopathy. In dilated cardiomyopathy, scars do tend to gravitate to be around the mitral annulus, all right? And so this particularly applies to that. These are some examples showing what we just talked about. These are separate, a series of patients. The ones on the left are epicardial. The ones on the right are endocardial. Let me just point out here. When we say epicardial VT, we mean they ablated it on the epicardium. When we say endocardial, it means it was ablated on the endocardium. It doesn't mean that it's just where the scar, where you were able to get it. So clearly in all of these, there's a positive, there's no positive deflection. There's always a Q in the lead 1, whereas in the inferior leads, there is a Q in the endocardium. So that's one example to keep in mind. This is a very tricky area. This is called the left ventricular summit. It is close to the base of the heart. It is bounded by the circumflex, the LAD, and the great coronary vein. Not only is it difficult because the coronary arteries are very close to you, usually there is a thick layer of fat your ablation will be very ineffective. This is the experience from 23 patients that were mapped to the left ventricular summit. The epicardial access was obtained, and they did not attempt ablation in 9 of these patients. They did attempt in 14, and they had acute failure in 9 and acute success in 5. Out of those, 1 did not succeed later on. What are we saying? This is from Penn, again, a place that wakes up and goes to sleep doing VT, and still, from the left ventricular summit, they had a very poor success rate. One example is here. This is from a different group. They did, this patient shows up, and does he meet criteria? Yes, he does. Right lead 1 is a QS, and the inferior leads are positive. And then, sure enough, it maps to, this is endocardial and epicardial maps. Pay attention to these electrograms. This is activation map. Yesterday you heard how activation map is very helpful. And the RVOT is even with the QRS, it doesn't beat it. The same as with the LVOT from endocardium. But when you go to the epicardium on the now you're beating the QRS by something like 20 milliseconds. You're early. The unipolar is negative. And there's all this late fractionation, this fractionated electrogram, which is also seen even in sinus. This is the pace map, and it's a 12 out of 12 match. But it's in a tough area in the stomach. They were not able to ablate. They sent him to surgery, and that particular case they were able to do with alcohol ablation. Okay. I can finish in 1 minute, sir. I think it's important that we talk about complications because we sometimes get excited about technique and we need to know what we're getting into. Obviously, you're right in front of the right ventricle. The problem is not puncturing the right ventricle once. You can get away with it. And then you do it twice, and then you do it 3 times. Now you better watch out, all right? Worst of all is when you puncture the RV and you don't know it. You go one way, you come out the other, and you think you're in the pericardium because the dye is layering. You put your sheet, and when does the disaster happen? When you're finished. Now where did this come from? This is Cleveland Clinic telling us that this has happened. So now we know that these things are going to happen. Hemopericardium may be from puncture of a vessel or puncture of the RE, but also just some patients just are more friable and delicate. Anytime you're manipulating the catheter going back and forth, they start bleeding. Air in itself is not necessarily a problem that will resolve. And then almost everybody that you violate the pericardium in will have pericarditis. You need to treat them with colchicine or non-steroidal just for a few days. This is an example just to kind of illustrate for you how the access is obtained. You can see the sheath there as it enters, but your relationship to the diaphragm is very clear. This can be a problem. If you puncture below the diaphragm, now you may violate the liver and cause a hematoma in the liver, and this can, or you could violate one of the epigastrial blood vessels, and you can have a retroperitoneal hematoma, which could be horrible, or as in this case, this patient had a large liver hematoma. So these are things to keep in mind if you entertain this procedure. I thank you for your patience.